This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago 2014. I'm Tom Luescher, Editor-in-Chief of the European Heart Journal, and I'm talking to Nell Barre-Mertz from the Cedars-Sinai Heart Institute. Welcome.
I'm glad to be here.
So we're talking a little bit about gender issues, about ischemic heart disease in women. Why is this important?
Certainly in the U.S. and in many European countries, women now are the majority of victims of ischemic heart disease. And as 51% of the general population, this strikes us as something that is probably related to either gender-specific diagnostics or treatment strategies and or sex-specific differences in disease pathophysiology.
And what is specific? What is the problem in women in particular? Is it the diagnostic challenge, or that you may have false positive or false negative aspects? What is the challenge?
There's a lot of challenges. As we know, ischemic heart disease is multifactorial and fairly complex. Yet there probably are some dominant overarching themes that are noteworthy. One is that 20 years of research in the WISE, which stands for Women's Ischemia Syndrome Evaluation, has uncovered this coronary microvascular dysfunction, meaning women more often do have ischemia in the absence of obstructive coronary disease, that it portends an adverse prognosis, and that traditional medication appears mechanistically to improve it. So we're thinking now that false positives actually don't exist, that these women, often middle-aged women with ST segment depression or reversible wall motion abnormalities or even a reversible SPECT, it's probably real. It's probably real.
I did a lot of casts in women, particularly elderly women that have angina-like symptoms, but often we're not sure is this diastolic dysfunction. They have smaller hearts, particularly when they age, or is it a microvascular dysfunction? So how do you distinguish the two?
Well, we are increasingly testing the hypotheses and finding some consistencies that microvascular dysfunction likely leads to this heart failure with preserved ejection fraction. Okay. These women often have elevated filling pressures in the absence of, reduction in EF. They don't have valvular disease. We also are presenting at this meeting connections with probable systemic microvascular dysfunction. Urinary microalbumin, for example, is correlating with some of the invasive measures that we can test in the coronary circulation.
And so often, that is, at least my clinical experience, is difficult to treat. So what do we do in this condition?
So heart failure with preserved ejection fraction is difficult to treat, and an outcome, again, of our gendered protocols where our heart failure studies to date dominantly studied heart failure with reduced ejection fraction. We're pretty good at that now, so we need to turn our attention to HFpEF.
But that also exists in males, isn't it?
It does exist in males, although it is a dominance of women, not 90%, but most cohorts of HFpEF are more women.
That's true.
Microvascular angina is actually not that hard to treat.
So what do you do? What do you give?
We use a lot of alpha-beta blockers. These women also have high
combined alpha-beta.
Well, labetalol, carvedilol, nebivolol. We also have demonstrated in small mechanistic randomized controlled trials, placebo-controlled, that ACE inhibitors help. Renolazine improves SAC angina scores. Eplenorone appears to be effective, and sildenafil.
All right. Okay.
So it's angina. It's not so hard to treat.
And what is your diagnostic workup? Are you using myocardial perfusion imaging or stress echo, or what are you using?
We right now, ready for prime time, is PET. Most places don't have PET, so we are finishing a 5-year study now, and it's looking quite good for cardiac MRI, for perfusion reserve, stress MR. You also, of course, can always do a coronary flow reserve,
Yes.
which is similar to an FFR. It's just you don't have an obstructive
Right.
lesion, so that's done invasively.
Yes.
And then some centers are doing stress echo, interrogating the LAD. That's technically very challenging,
Yes,
but we're quite optimistic that stress MR is going to be a good, non-invasive, good enough, probably as good as SPECT would be for obstructive CAD.
Primarily, it's a coronary flow reserve. That's
Here's what we do. It's an adenosine or regadenosine stress. It is a gadolinium isotope, and then we visually look at it as you would for any ischemic heart disease. And sometimes you will see that subendocardial ring of reduced. But we also calculate quantitatively a myocardial perfusion reserve index. Okay. And there's commercially available software that works for that, and it's working quite well in our hands.
Now, women also can have, of course, coronary artery disease, true coronary artery disease, and often it is said that it presents itself differently. Is that your experience too?
It's controversial, but here's the controversy. The very large registry studies that take all comers, all ACS comers, all angina comers, very clear that there are sex differences. Men are more likely to have the typical angina that we learn about in textbooks. Women can have that, but less than 50% of the time. Women are more likely to have atypical symptoms, often attributed to the stomach, reflux, nausea, and also extreme fatigue and shortness of breath in the absence of chest pain. So that is the atypical presentation in women. That's a little over half. It's controversy because some people say for example, they'll do a cohort where everybody had to have an angiogram, and then they'll show that men and women had the same type of typical angina, atypical angina. The problem with that is that it's a cath lab bias, and it is you and I deciding that patient should go to the cath lab, and of course the patients with the more typical symptoms will go to the cath lab.
Likely to be there, yes, yes. And so, what is the best test? I mean, the exercise test often does not work very well in women. In fact, the NICE group in London, they said it's useless to do it altogether in women. What's your position there?
Yeah, I think we would disagree. Our guidelines were recently reevaluated. We did the randomized controlled trial called the Women Study, and that demonstrated that among women that are able to exercise and have an interpretable ECG, there was no additional benefit to adding imaging on top of a regular exercise stress test.
So the false positive and false negative was similar?
Well, again, you have to ask what is your gold standard. If it's obstructive coronary disease, we know that up to a third of women that go up to the cath lab with signs and symptoms of ischemia will not have obstructive CAD. They have likely this coronary microvascular dysfunction. So if the gold standard is prognosis, these tests work very well for risk stratification. If the goal of testing is diagnosis of obstructive coronary disease, you're right, the sensitivity and specificity is not as high, but that's because the prevalence is lower.
And so if you were to do a perfusion test, can you distinguish coronary disease and microvascular dysfunction? I
don't think that we would be able to say that. In our WISE population, among the women that had the microvascular coronary dysfunction, only about a third had that traditional imaging pop up as abnormal, stress echo, stress SPECT. Yet often they have exertional angina, often they have ST segment depression. The problem likely is that, again, these modalities, stress echo, stress SPECT, designed in men, for men, by men, to pick up the man's disease, which is obstructive coronary disease. So it's not going to be as sensitive or specific because it wasn't designed for that purpose.
So eventually you're going to do a coronary angiogram anyway to really...
Well, if they're high enough risk, I mean, it's not unreasonable, and as you know, we have a big NHLBI-sponsored ischemia trial. It's not unreasonable in someone who has a relatively, an abnormal stress test, but a relatively good prognosis. Calculate that Duke treadmill score. If their prognosis is reasonably good, it's not unreasonable to deploy optimal medical management for their signs and symptoms of ischemia, because they probably have ischemia.
Yes.
And optimal medical management appears, well, it works well in big trials if you have obstructive CAD, Courage, Berry 2D. If you don't have obstructive CAD, that's the trial we need, and that's the trial that we're actually trying, we're under review. It's called Ischemia-WISE.
All right. So the take-home message is that microvascular dysfunction is more common in women, and that we should consider that and treat it appropriately with alpha-beta blockers. Can we say that?
Well, and here's what we actually, I didn't get to say all the things that we do. The randomized controlled trial will actually stem from our intermediate outcome trials, where a maximally tolerated dose of an ACE and a maximally tolerated dose of a statin. Some Italian investigators did a small mechanistic trial with that combination, and they improved ischemia markers in a cohort of patients with coronary microvascular. And men can have it too, so.
Right, there's some overlap here.
There is overlap. There's always overlap, thank goodness.
Thank you very much indeed for coming.
All right, thank you.